We've kind of wandered along a lot of different levels of topics today, from like macro medicine, systems biology approach to entire healthcare systems, down to people talking about looking at literally single cells. So I'll try and stay somewhere within those bounds, and maybe kind of as I'm listening, bring up things that people have touched on and that all of us, I think, are trying to tie together in some way for both individual patients and then our entire patient populations. Um, I do have to show my disclosures, that I do have some relevant disclosures. And kind of looking at some of the pictures and thinking about things that people have been talking about this morning, I just wanted to show a variety of pictures to really kind of bring home that we're talking about not one disease. And it was long suspected, when it was first described, they called it multiformy because they recognized immediately that it takes multiple forms. We know that's true at so many levels now, and more deeply than before. But when we meet patients that all carry the same diagnosis, we meet people with tumors that look like this. We meet people with tumors that have minimal contrast enhancement, but this more infiltrative gliomatosis cerebri pattern. And we deal with tumors that look like this, where tumors are actually spreading through cerebrospinal fluid. So people with the same diagnosis, people who get called the same disease, people whose cells get submitted to different researchers and analyzed, it's not just at the molecular level that they're different. They are very, very different and heterogeneous in their appearance, in their behavior, and in their underpinnings. And I think when we start talking about immunotherapy, we really have to be ready to deal with an even extra level of complexity, because this is really kind of a host-parasite interaction, where you have a disease that is constantly changing, is multifocal and heterogeneous in every single one of its cells. And then you have a host, the patient, whose immune system is also changing and responding in a really dynamic and heterogeneous way that we really don't fully understand. And then when you try and put those factors together, it gets even more complicated. So we need people like Nitin and others to kind of tell us about the systems biology approach and bring together people from different disciplines to try and get a better understanding on this. But kind of this one approach, one molecule, one drug, it really just doesn't make sense when you get any kind of grasp of the conceptualization of this disease. And I think, as multiple people have cited, the pediatric oncology world was way, way, way ahead of everybody else in this. When they started seeing true successes in pediatric oncology, it's when they started combining multiple drugs that work in multiple ways. And they were ahead of us by 30, 40 years in that, but really made headway. There's a little bit complexity because the way that drugs are tested and approved is used to thinking very simplistically, and we have to finally heed the success of our colleagues and move beyond that. So hopefully we're finally getting to that point in the not so distant future. So like I was saying, when you look at these cells, they really have very, very different cell types within them. If you get samples from little different parts of the cell, they look really, really different. You're dealing with tumor stem cells, you're dealing with necrotic areas of dying cells, you're dealing with cells that are infiltrating or palisading and moving away to either flee conditions that they don't find favorable, or moving towards areas and conditions that they do find favorable. You're dealing with infiltrating immune cells of many, many different types, some of which are actually protecting and sustaining the tumor cells, some of which may be trying and failing to attack or control or limit the disease. And really interestingly, like Vivian Tabar and a few others have shown, the abnormal blood vessels, some of them are normal blood vessels that have been induced to respond and open up around the tumor. But some of those vasculature cells are actually tumor cells that are no longer even glial, but they're actually forming tumor vasculature. But if you look at them at the single cell level, they carry the mutations that prove that they are actually tumor cells that are blood vessel cells. And they are different and distinct. So we're dealing with lots of different things within this one tumor that kind of is all given one name. And you can see that in the very, very basic pathology slides. I think the main point here is that you cannot draw a line. There is no border. Even on MRIs where it looks like there is a firm border, and even in patients who get gross total resections where they have a wonderful MRI and their scan looks perfect or near perfect, what we really know at the pathologic level is that there are tumor cells and reactive cells far beyond what we see on the MRI. that we have to address and think about. So this is not a local disease, but it is a brain-wide disease, and it has the potential to cross barriers and move into new areas. So when we talk about drug delivery, we also have to hold that into account. That's also seldom discussed in immunotherapy, but different compartments. People just talk about the CNS, but actually different parts of the central nervous system are different in their ability for different immune cells to infiltrate and respond within. And then we start talking about leptomeningeal disease through the CSF, that is a different immune environment. So anything we talk about for immunotherapy has to kind of remember that and bear that in mind, that as the tumor moves through different tissue, the immune system is not exactly the same in its ability to reach different areas. And different areas of the brain have different tolerance for how much inflammation and what type they will tolerate. So going back to the multiforme base of this disease, the immune system too, you have to think of as this really, really complex process, parts of which are beneficial, parts of which are extremely harmful, and you're dealing with very, very different cell types. They interact with the tumor blood vessels as well as normal blood vessels in both positive and negative ways. So there's multiple different cell types that you may want to stimulate or suppress. They interact with each other in ways that are really important, and then you have to get those cells where you need them to go to interact with each other. If you're trying to get a drug into the CNS to CNS resident immune cells or ones that have been drawn into the tumor and taken on a phenotype that helps the tumor itself, you have to be able to get your drug into there as well. There's a lot of enthusiasm about antibodies, but the ability of some of these large antibodies to cross into the CNS, if we want them to interact with CNS resident cells, is somewhat restricted, but obviously less so than we used to believe. But there's kind of a dearth of literature on that, even for things that are in common clinical use today, of knowing how different kinds of antibody types truly penetrate into the tumor itself, and not just into CSF, which is easy to obtain. So I really like this quote from Dvorak about cancer being a wound that never heals, because the other thing that we talk about is when we talk about immunotherapy, well, we used to think of vaccines, you're talking about vaccinating somebody against something that shouldn't be there, against a virus or a bacteria that should not be present in the body. But we have to remember that cancer cells do come from our body. So they have their passport and their visa to be present within the body. And the immune system has all of its appropriate checks and balances to recognize what is something that came from it and what is not. And the system where it's supposed to recognize body cells that have become dysfunctional or damaged or abnormal is very, very tightly controlled. So when we talk about vaccine therapies, it really is very wildly different immunologically than vaccinating a person against something that is not supposed to be in their body, especially something that is changing. So it's kind of like if you could imagine someone trying to vaccinate you against a wound, it doesn't seem to make much sense, but that is kind of what we're talking about. When we do talk about abnormal antigens, I think there's a lot of promise and a step forward there, and I do want to talk a little bit about the rindapepimut trial a little bit later as an example of that approach and what we can learn from it in both good and negative ways. Just briefly, because people have cited this before, we do have to operate within the context of changing standards of clinical care. So as we're learning about the aspects of this biology, a new standard of care came out in 2005 with adding temozolomide, and then we kind of had to catch up after the fact and learn who are our responders and non-responders. So certainly when Dr. Hood was showing what I thought was a fantastic slide about kind of the inefficiency of modern simplistic clinical medicine, where you put large numbers of people on drugs, some of which are very expensive, but really you're only getting a benefit in a small subset of those people. It just is very wasteful and inefficient. But that's what we've been kind of forced with our current system. So we're giving temozolomide initially to every single patient, and only after the trial, because the trial was designed that way and well and to be learned from. Initially, you give temozolomide to all of your patients, but after the fact, we learned that you do have a fairly reliable biomarker that it is a minority of patients who are responding to the drug. So then you probably don't need to be exposing all of your patients to the side effects in the population that is very unlikely to benefit from it. And from a healthcare system standpoint, you don't need to be wasting that money on people who are not going to benefit from that drug. So then if you're in a group that's going to respond, that's nice news for you. But if you're in a group that's not going to respond to the drug, you need to come up with an alternative. So we're already talking about taking people who've been labeled with one diagnosis of GBM and now splitting into smaller and smaller groups. And it starts to approach the situation that we were referring to about dealing with small numbers of patients with the disease, and then how do you convince a drug company to get financially interested in funding a trial when you're talking about smaller and smaller pieces of a pie. So then as this other progress with different dendritic cell vaccine and immunotherapy approaches has been evolving, there is another new standard of care with the approval of the Novo TTF device, and that adding this device on to standard of care after the completion of radiation and temozolomide and during maintenance therapy with temozolomide showed a significant benefit. This is kind of a new challenge that was not on most people's radars, but and the mechanism of which is not fully understood yet. Unlike a lot of the other drugs that have been in the system, we think we know that this device works by altering the physical mitosis and then the tubule structure that allows for invasion and migration and movement of tumor cells, and then fortunately seems to leave the normal cells completely unaffected because they're not using those pathways. What we really don't know almost anything about yet is how does this device then interact with some of the other things that we're thinking about in the biology of the disease. How does it affect tumor vasculature cells? How does it affect normal blood vessels? What effect, if any, does it have on immune cells of the many and various subtypes and their movement and migration? And there's really a dearth of research on that topic, but then we talk about wanting to add these things on to what is now the standard of care in this disease, but not utilized by all patients. We don't yet know for this what we know about temozolomide and MGMT. We see that there's clearly an average benefit and that it is a sustained one, but we don't know, like we do for temozolomide, is that a benefit that's seen, which is a big benefit for a minority of patients that we don't know how to identify or predict who they are, or is it a little benefit that's true for everybody? So hopefully there'll be some follow-up studies that then help us predict and find that out, and then rationally apply this therapy to the people who will benefit from it the most, and then not waste it or put up with the side effects in people who may not be benefiting. But I don't think we know enough about the biology of this device yet to really determine that and move forward in that direction, but we're going to hopefully need to. So then referring back to what people have touched on from the Cancer Genome Atlas, we're now kind of getting multiple layers of that people have referred to before. So kind of the first couple layers of data were about genetic molecular signatures, RNA expression, and protein expression, breaking down GBM into 3 to 5 subtypes. I think most people accept now that there's at least 4 to 5, with some rare variants that are driven by certain believed to be baseline driver mutations that then lead their behavior. So what do we know about these different subtypes in the context of looking at broad spectrums of disease and applying rational therapies? In addition now to the molecular subtypes, as a couple people have touched on, people have now looked back and said, how does this relate to immunotherapy? And separate from different tumors having different common antigens or kind of antigenic loads or numbers of mutations and abnormal proteins that might be targets for different immunotherapies, there's also been a small amount but really nice work looking at the different subsets to say that some of these tumors have a greater preponderance of kind of immune suppressive phenotypes within them. Like especially the mesenchymal subtype clearly carries kind of these immune-mediated tumor supporting signals like STAT3 and interleukin-6. I'm really interested in Amy Heimberger and her group's work on that topic, and that some of these may relate to kind of the broader immunotherapies like the checkpoint inhibitors of CTLA4 and PD-1, PD-L1 system. Other tumor subtypes really don't have that signal, so maybe we should not be putting people with those kinds of tumors into those trials. Not much clinical work to really tell us if that's true or not. But again, if we just put every patient who has a diagnosis of a GBM into these kind of broader immunotherapy studies, we may really be diluting the signal of who's benefiting or not. So hopefully kind of that basic work will go on in parallel or in tandem with the immunotherapy trials to make sure that we're putting people in the trials to really find out if the drug works for people who it should work for and it's rational for, and then not diluting our signal and kind of throwing out a baby with the bathwater by including people in the trials who are very unlikely biologically to benefit from a particular treatment. Certain other things, I think often what gets ignored is the negative data, but in some ways the negative data is often the most interesting to me. So though certain subtypes clearly had certain signals for immune suppression or potential benefit from checkpoint inhibitors, there were certain kind of universal things across the different subtypes. So one of the ones that interested me the most was this signal that across all the tumor subtypes, you saw really kind of dramatic reductions in interleukin-2, which is an incredibly important cell growth, stimulation, and survival signature for T lymphocytes. So that would possibly suggest that anything you do for any of these tumors that depends on activated T lymphocytes getting in, surviving, and doing their job will not work. Because without sufficient interleukin-2, you cannot sustain a proper T lymphocyte response. Some of the innate immune cell signatures across the tumor types did also appear to be not very different. So this may help guide us in the kinds of immunotherapies that may not work regardless of type, or that may be theoretically beneficial across the various subtypes of cells. So we might not have to divide up every little tumor type into its one little slice and do that little trial for that rare subset of diseases. There may be things that we can say, this should theoretically work for everybody with this diagnosis, and there may be times when we can kind of lump groups together. So I thought some of this work was extremely interesting, and it's interesting that it kind of correlates with the molecular subtypes very, very tightly, some of which makes sense and some of which there's not really a logical known reason why that would be. And it raises some questions like Nitin referred to when you talk about systems biology, how much of this is cause and effect versus just a correlation. So the GAP project, I think, kind of takes things forward a little bit to the next level that we discussed earlier in thinking about when you look at one tumor and look at different parts of it, how is it different? And right now we just kind of classify, we say somebody progressed and well, what we were doing didn't work. But we could potentially take data like this and when people do progress, we could look at, well, where did they progress? And does that tell us which biology of their tumor is the part that was resistant to treatment? And when Dr. Hood was kind of showing the Hubble telescope and the stars, I actually really liked that picture, and talking about that these things exist in 3 dimensions. They really exist in 4 dimensions, with the 4th dimension being time. These are tumors that evolve and change. They're already multiple cell sets with the host's immune system interacting with them in a 3 and then a 4-dimensional way. Our patients don't die of the tumor that gets resected. They die of the tumor that comes back after treatment. And people say, oh, well, we can't get that tissue. But the reality is, the benefit of re-resection has been kind of confirmed over and over. And we do get that tissue. And that's really what we should be learning from the most is what is the biology of the tumor that comes back? How is it resisting disease? We've learned some stuff about radiobiology, about mechanisms of radioresistance, but we're going to have to expand that substantially. What are the mechanisms of angiogenesis resistance? What are the mechanisms of molecular resistance from these agents? And then what are the mechanisms of immune resistance if we treat people with immunotherapies? If we can mount an antigen-specific immune response and it infiltrates the tumor, why then does the tumor come back? And again, the rindapepimut study might give us just a little hint of how those studies can be done, and we can learn from them and move forward. So these are kind of the different points that I've already been talking about, but really kind of focusing on what's going on within this entire complex tumor of different cell types, how is that changing over time, and how are all of those cell types interacting with the treatments that are given and the host's immune system. If we're going to really be successful with immunotherapy, we have to really learn about each of those things. And then people from these very widely different disciplines have to form fruitful collaborations and really understand what each other are doing rather than kind of looking at things piecemeal. And that's where we need our systems biology statisticians to help us out. And then how do we apply that kind of data that's complex to clinical trial epidemiology, which is really used to just looking at controlling one factor at one time and then waiting to see what happens. So a couple other points that come to mind going back to the immunotherapies. There are some really kind of studies that I think didn't get that much attention, but kind of point out some actually simple things that surprisingly there are single factors that are predictive. So some of the studies that have been done that Dr. Cobb's mentioned and various other work saying that the immune system systemically clearly goes through changes long before people are diagnosed. There's interesting stuff looking at allergy predispositions in people who later develop glioblastomas and gliomas. There's immune markers of that people have gone back and looked at prior to diagnosis. There's the Scandinavian study that found immune responses long before people were diagnosed with disease that clearly predicted something was wrong with their whole system. And then some pretty simple studies looking at something as simple as CD4 counts. So there's a group at Hopkins that looked. So we know that temozolomide causes a selective CD4 lymphopenia compared to its effect on other immune cells. And it depends on the MGMT expression, not of the tumor, but that CD4 cells actually don't express much MGMT naturally, so that's probably why they're more affected by the temozolomide. There should be a homeostatic response within the immune system that recognizes it doesn't have enough of that cell set, sends out cytokines to stimulate their release and generation from the bone marrow, and that doesn't seem to occur. And what this group found was that patients who were on standard treatment, a subset of them really had significant declines in CD4 counts, and that there was a very strong correlation between low CD4 counts in these patients and their overall survival, and that did not relate to infections. That would be the obvious, well, they had a weak immune system, then they had a serious infection, and that's what happened to these people, but that was not the case. And it may be that something that simple, which is a simple blood test currently available, could actually give us an early warning sign of before there's clinical evidence or MRI evidence of tumor progression. We also really don't understand that much how bevacizumab affects the immune system. We know VEGF and its receptors are expressed on the various immune cells in different ways, and it does decrease some aspects that we think are important for immunoprotection of the tumor. So we may be able to leverage things that we already are using, have currently available, if we just understand them a little bit better. But we'll need to be looking at these things together with these kind of more complex immunotherapy trials. People kind of looked at these things in a very simplistic way and said, oh, well, if we weaken people's immune system with temozolomide, immunotherapy is not going to work. But we've known a long time before that when the immune system has a mild lymphopenia, that's actually when it's most responsive to things that stimulate the immune system, including just normal vaccines. So the Samson and the others that did the rindapepimut trial of EGFRV3 vaccine clearly showed that when they gave the vaccine, when people had the greatest CD4 lymphopenia, that's when they actually saw the best responses of antigenicity, because you were stimulating naive CD4 lymphocytes that had just come out fresh from the bone marrow, and there was plenty of interleukin-2 around for the CD4 cells to soak up and respond to and kind of start a new immune response. So the EGFRV3 vaccine, most people in the room know, this is a failed study, so this is a negative study that I do want to talk about because I think it's an example of ways we can learn from studies, and I think we should plan all studies in a way that we can learn from them, even if they are negative studies at the end of the day, rather than not learning from why something did not work. So this was a nice example of a simple, straightforward vaccine study. EGFRV3 is expressed in a subset of GBMs. It is a neoantigen. It is not expressed in the body. The immune system should recognize that it's not normal. It's right there on the surface. It's a good antigenic thing for the immune system to respond to. So this was a really good, straightforward concept that made a lot of sense. They clearly showed through several studies that you can vaccinate people and stimulate a systemic immune response to that antigen. It should not cause reactions anywhere else in the body because other cells don't express this oncoantigen. So they set up a nice, well-designed study. They had people with near total resections of their tumor only, which has kind of become a trend, but there's been this assumption that tumors that are bulky and have that immune suppressive local environment will not respond to immunotherapy, but there's really not that much data to prove that that's true. So again, we're kind of looking at a small subset of patients from the very get-go. So when you talk about people who have EGFRV3 and a gross total resection, probably about 1/9 or 1/10 of total GBM patients were the people that were even eligible to be in this trial to begin with. based on some rational stuff and a theory, but not much else. The first two studies, three studies really proved that this was a safe thing to do, and there was some suggestion that it was beneficial, so they proceeded to a large randomized phase 3 trial, and at the end of which there was absolutely zero benefit whatsoever. However, I think we learned some simple basic things and verified a few others from this trial, that you can stimulate an antigen-specific peripheral immune response. There was data that they collected that those immune cells did penetrate into the tumor tissue and create the kind of immune response that you'd want. And they did some nice kind of simple, reproducible, widely applicable biomarker studies saying that yes, you can stimulate these cells. They're the right kind of cells responding to the right kind of antigen. They do have the kind of surface surface receptors that can home them into the central nervous system. And that they do hit their target, and that you're also producing the right kind of cytokine milieu for these immune cells to be active ones and not regulatory or weak. And that you could really do studies looking at the timing so that you can leverage effects of the treatment patients are already on, temozolomide, to give the vaccine at the right time to get the maximum response that you want. And what they found, Heimberger's lab did a work with a subset of patients where they did take out the tumors of the people who failed and had progression of their tumor, and they clearly showed that on the top, the person had amplified EGFR in the tumor cells. They had EGFR V3 in the top right on the surface of the cell. When the tumors came back, there was no more V3 on the surface. They had completely wiped it out. You could not find it anywhere in the entire tumor, but the tumors clearly were growing anyways, and interestingly, they also had re-amplified EGFR signaling for cell growth, even though they were not expressing the abnormal receptor anymore. So I think they were doing the right kind of things from the get-go to learn from the trial, no matter what happened at the end of the trial, whether it was beneficial or not, to teach us a little bit more about the immunobiology of this disease. So I just want to talk about a couple other trials we're waiting on results for that are slightly different. So DCVax has been going on for quite some time, and this is hopefully a multivalent type of vaccine, not just against one antigen. It's derived from patients' own dendritic cells, so you have the patient's own individualized immune system, and then you're pulsing and stimulating it with the patient's own tumor lysate. So you don't really know what antigen you're stimulating or not, but it should be patient-specific, and it should be specific to their own immune system, which should theoretically be good from a safety standpoint. And again, they had this requirement that people had to have a gross total resection, because they needed enough tumor tissue to then do the tumor lysate and create the vaccine, but also partly for this theory that's really never been proven that if you mount an immune response but you have a bulky immunosuppressive tumor environment, it won't work. But again, we've never really proven that for sure, even though it should be a sound theory. It's something that really could be looked at in a small subset of people and established, should we be designing the trials this way or not. So they have completed accrual to this trial, and the patients are being followed. We'll hopefully get results later this year. I think one of the advantages of this trial is that it's multivalent in the sense that you should be getting the patient's own tumor of whichever subtype it was or is, looking at whatever antigens are present rather than just guessing and applying it across to a really heterogeneous population of patients and tumors. But this trial was designed before NovoTTF was approved, before some other things have come into standard practice. So they also designed it to allow crossover at progression, which may create some statistical problems in analyzing the data. But it'll be interesting to see the results of this trial, and then hopefully a lot of kind of the more basic science and translational investigations into it, if they acquire tumors at progression, and then look at kind of biomarkers, tissue markers, and serum markers of the immune response in the study, so that either way that the outcome is for this trial, we learn a little bit more about immunotherapy from doing it. And then kind of in a slightly different vein, there's also the ICT-107 trial that's actively enrolling worldwide right now, where you're also taking patients' own dendritic cells. However, you're sending them to a central lab, and you're kind of stimulating them against a panel of common antigens that should be variably expressed across the different heterogeneous tumor subtypes. They are getting tissue biomarkers of the study to hopefully confirm in individual patients whether they did give a vaccine that stimulated an immune response that should have worked for that individual patient's tumor. Again, we're looking at a very, very select subpopulation of patients, however, in which there's absolutely no residual tumor after surgery. And then we're taking that subset of patients and then literally cutting them in half because patients have to have the appropriate HLA type for this process to work. So again, we're looking at a really small subset of GBM patients as a whole. So then when we interpret the results of any of these trials, we have to really ask ourselves, what does this mean for our entire patient population? And as trials are looking at smaller and smaller subsets of patients, it's going to require greater and greater collaboration across different centers and really running worldwide trials to get the numbers of patients that are eligible to get in the trial to begin with. I think I'm almost up for time. I will stop there, but I'm hoping that we will learn a lot from these immunotherapy trials. People are already talking about taking them into kind of the second and third generation of starting to combine these various immunotherapies in different ways. Can we combine, targeted vaccine therapies together with checkpoint inhibitors to augment them and kind of broaden the immune response across different subtypes? Is that something that's safe to do when you create a less specific response? Will it augment things? And then one picture that's emerging in many of these immunotherapy trials is that if we do stimulate an immune response and inflammation within the brain, then we're dealing with patients who present to us with inflammation in their brain, which can be very clinically symptomatic. So then we need to kind of go back to our really core basic clinical care of patients, because we're going to have to be able to symptomatically support them to get through the symptoms clinically that they'll put up with when they're in these trials. And then we'll have to kind of resist the urge to constantly give immunosuppressive steroids that may get them through the reaction they have to the treatment, but also blunt any effect that it might have. Any questions?